everyone, happy evening. Welcome to our episode 17 of Winsome Wednesday with Dr. Nikita. And I'm Dr. Nikita here, your mentor for NEETPG and your mentor for Next. Is the audio visual clear now? Yes, great. So finally we are here, and I think it's quite some time that we are having this academic session in Winsome Wednesday. In the meanwhile, recently we had interviews with some of the toppers, and they shared their insights, their preparation tips and strategy, and I hope all of you have benefited out of it. If yes, please let me know in the live chat if you would like to see more toppers sharing their tips and strategies so that we can have more such sessions. So now the agenda for the today's Winsome Wednesday episode is to discuss the high yield MCQs. Now these MCQs are picked up from the quiz that we had recently on our third month birthday of the Telegram group, that is 1st of July. So I had promised that I would be discussing those, sure that you download that PDF as well from the Telegram group. Alright. Yes, hi everyone. Yes, hi Puneet, I'm good. How are you? Alright, so let's start with our today's session. So the first question, now I'm starting with this question because I'm starting with this question because this question had the least accuracy in the quiz by the students. So this question was found to be most difficult by the students. That is why I'm starting with this question. Again, this is a numerical in your general pharmacology. Recently, I discussed the numericals in my Winsome Wednesday and on Unacademy as well. All right. So let's quickly jump to this question. So a 30-year-old man is brought to the emergency department in deep coma. Respiration is severely depressed and he has pinpoint pupils. His friends suggest that he self-administered a large dose of morphine. We know pinpoint pupils, respiratory depression, morphine. And he had administered this 6 hours earlier. An immediate blood analysis shows a morphine blood level of this much. Assuming that the volume of distribution is 200 liters and the half-life is 3 hours, how much morphine did the patient inject 6 hours earlier? So basically, to give you the scenario, so suppose at a particular time, that is, let us say at a time X, that this patient injected some dose of morphine. Now 6 hours later, the patient has come to the emergency department and the plasma concentration now, the blood level is 0.25 milligram per liter. Half-life has been given as 3 hours, right? And the volume of distribution has been given as 200 liters. What do you think would be the answer to this? Purnendu says option D. Yes, it is the right answer. So let me tell you how do we solve such questions. Now whenever you are given half-life and you are given another time period, generally it is in the multiples of the half-life. Now you are given that the patient came after a duration of 6 hours and the half-life is 3 hours. So basically the patient came to the emergency department after how many half-lives of morphine? After how many half-lives? So 3 hours is 1 half-life. So 6 hours would be 2 half-lives. 6 hours would be 2 half-lives, right? So 6 hours basically is equal to 2 half-lives. We had seen in the last episode of Winsome Wednesday, right, and in the Unacademy sessions as well, that when you have 2 half-lives, how much is the plasma concentration? How much plasma concentration remains after 2 half-lives once you have stopped the infusion? So if this is the graph which I have to show you, once you stop the infusion, the plasma concentration goes on decreasing. This is the plasma concentration and this is the time, right? So the plasma concentration goes on decreasing. After 1 half-life, the plasma concentration, half-life, 1 half-life 50%. After 2 half-life, how much is eliminated and how much remains? Yes, tell me. How much is eliminated and how much remains? Absolutely right. So 50 plus 50 of 50, that is 25. 75% is eliminated. So what remains in the blood now is 25%. So we know that after 2 half-life, the plasma concentration is actually 25% of the original. Now a patient also has come to the emergency department after 2 half-lives, and the concentration given is 0.25 milligram per deciliter. So now we know that this 0.25 milligram is actually 25% of the original, right? So if 25% is 0.25 original, that is how much would be 100%? How much milligram per deciliter would be 100%? Yes. If 25% is 0.25, that means you are putting 2 decimals. So 100% would be 1 milligram per deciliter. 1 milligram per deciliter. So that means the original concentration, that means the starting concentration which the patient had was 1 milligram per deciliter. This is the plasma concentration. But the question is asking that how much morphine, that is, the question is in milligram. The question is not in plasma concentration. The question is in amount of morphine. So we know that what is the formula that we will be using here? What is the formula that we would be using here? I discussed the formulas. LVP, right? LV Prasad Institute, remember that loading dose is equal to volume of distribution into plasma concentration. Now volume of distribution has been given as 200. It has been given as 200. So you have 200 liters into 1 milligram per liter, not deciliter. So 200 into 1 is equal to 200 milligram. So that is why the loading dose is 200 milligram. So that is why the correct answer is option D, that is 200 milligram. Is it clear with everyone? Yes? So I hope now you get it. So always when you're given the time period, check how much is the time period in multiples of the half-life. How much is the time period in the multiples of half-life? Alright. Now suppose if I tell you, if I change the question now to see whether how much of it you have understood. Now I change the half-life from 3 hours to 6 hours and the patient comes after 6 hours. The rest of the question remains the same. Now tell me what will be the answer. If I change that the patient presented to the image, the half-life is 6 hours, then tell me what will be the answer. Yes? Very good, Durga Prasad, Purnendu, Ramakar. I am so glad to see all of you getting it right. So 6 hours is basically the 1 half-life, right? So that means 50% of the plasma concentration of the original. So if 0.25 now becomes 50%, so that is why 100% would be double of that, which is 0.5. So the loading dose would be volume of distribution 200 into 0.5, that is half of 200, which is 100 milligram, right? So that is why in numericals, if you understand the concept, then no matter in whatever way the numerical is asked, you will be able to answer that question. Is that clear with everyone? Alright, let's move to the next question. Okay, so again this was a question which many students, they got wrong in the quiz. For students who are new here and who are not our Telegram group members, let me tell you, we have regular daily quizzes, plus in between we have live quizzes, which is actually a very fun-filled quiz. So make sure that you attend all of those. Now, as I say always, in the lengthy question, start reading the question from the last line. So which nerve was most likely to be affected? Now, I read this last line. This is the cheat code that you use. And I look at the options. So the options given are ulnar, superficial, radial, basically the upper limb nerves. Now, whenever I get such question and the nerve injury is asked, the number one thing when I have to start thinking, so I have to hunt for the clues in the question now to understand that what is the nerve involved. So before that, I would like to discuss with you in the upper limb nerve injuries. I hope all of you know the mnemonic. I've already shared in one of the classes, upper limb anatomy in a nutshell. So what is the mnemonic that we have to remember? Dr. Coma, right? Dr. Coma. What do we mean by that? That wrist drop, D stands for drop. Wrist drop is seen in radial nerve injury, right? Claw hand, C stands for claw. Claw hand is seen in ulnar nerve. Ideally, your total claw hand is seen with ulnar and median both. Either ulnar or either median causes partial claw hand. If you are just given claw hand and you have to choose one option, then choose ulnar more than median if you have both in the options. And MA stands for median nerve causes what deformity? Median nerve causes what deformity? Ape thumb deformity. Ape thumb deformity. Also, I had mentioned in the session, this is a free session on Unacademy, you can still watch it. Ape you can also write as AIP. AIP, right? So what is this AIP? AIP is that anterior interosseous nerve injury causes pointing index. It causes pointing index. So pointing index is seen in anterior interosseous nerve injury. Now in the interosseous nerve, you have anterior interosseous and you have posterior interosseous, right? So in the interosseous nerve, you have anterior and posterior. Anterior interosseous nerve, we know it's the median nerve ka branch, and posterior interosseous, we know the nerve of the extensor compartment. Posterior is your radial nerve. Posterior is your radial nerve. I hope all of you remember that as well, right? So now, keeping this mnemonic in mind, I will now hunt for the clues in the question. Now the clues are, I'm quickly looking for the clues. Absolutely right. There is wrist drop. There is wrist drop. There is weakness of grasp, but there is normal extension of the elbow joint. There is no loss of sensation. No loss of sensation. All right. So now tell me what will be the answer to this question. So we know that wrist drop from a mnemonic Dr. Coma, wrist drop is seen with radial nerve. So we have ruled out ulnar, we have ruled out anterior interosseous, we have ruled out median nerve. So either it is posterior interosseous or is it superficial radial, right? So what will be the answer? Absolutely right, it is posterior interosseous. Why not superficial radial? When will superficial radial become the answer? Superficial radial is basically the radial nerve. Superficial matlab superficial jane wala. So remember that it is responsible for the sensory supply. Sensory supply, right? So if there is loss of sensation also, that means then superficial radial is involved along with the posterior interosseous. That means the radial nerve is involved. Absolutely right. So loss of sensation tells you, no loss of sensation tells you that the superficial radial nerve is not involved. And we know that posterior interosseous, basically it is the deep branch of the radial nerve. Now my next question to you is, now we know that the radial nerve divides into a deep branch and a superficial branch at the level of the elbow, just at the elbow. Now this goes, the deep branch of the radial nerve, it goes between the heads, the two heads of which muscle? Can you tell me that the deep branch goes between the two heads of which muscle? Yes? Yes, I'm waiting for the answers. So remember that the deep radial nerve, it goes between the two heads of, no, not pronator teres. Pronator is related to your median nerve, not the radial nerve. So remember, do not make this mistake. It is the supinator muscle. It is the supinator muscle, not the pronator teres. Okay, remember that. So this is quickly to tell you. I'll zoom this image so that you'll see this, the radial nerve ka course. So you have radial nerve at the elbow here. right? You have radial nerve at the elbow here. You have the superficial branch of the radial nerve. This is the radial nerve. You can see that the deep branch is going beneath this muscle, which is the supinator, and this is the superficial branch. The deep branch becomes the posterior interosseous nerve, right? Also, in relation to the radial nerve, on the lateral aspect of forearm, you can see the musculocutaneous nerve. You can see the musculocutaneous nerve. And here, behind the medial epicondyle, you can see the ulnar nerve. So, if there is medial epicondyle fracture, there would be ulnar nerve injury. And here you can see carpal tunnel. You see the median nerve. This is the median nerve right in middle. Median nerve. So, carpal tunnel syndrome is the median nerve which is involved. Again, here you can see that the radial nerve, it goes in relation to spiral groove. So, that is why fracture shaft of humerus will lead to radial nerve injury. Then at the elbow, it divides into the deep branch, the posterior interosseous, and the superficial branch, which supplies the sensory branches in the head, right? So please remember this, the radial nerve. All right. Now going to the next question. Again, in spite of discussing this so many times, many students make mistake in this question. Now the question is, a 30-year-old man suffered a superior gluteal nerve injury. Suffered a superior gluteal nerve injury in a motorcycle crash in which his right lower limb was caught beneath the bike. He is stabilized in the emergency department. Later he is examined and he exhibits a waddling gait and a positive Trendelenburg sign. Which of the following would be the most likely physical finding? Now this is very important question, the Trendelenburg sign. Which nerve is involved and which muscles are involved? Please read the options and tell me what do you think the answer is. So the clue here is superior gluteal nerve injury on the right side and there is positive Trendelenburg sign. What do you think would be the answer to this? Absolutely right. Okay, so the correct answer is B here. The correct answer is B here. Now remember that in the positive Trendelenburg sign, basically you have the superior gluteal nerve which is injured. Now, superior gluteal nerve supplies which muscles? Superior gluteal nerve. It supplies the gluteal muscles. Which gluteal muscles? And inferior supplies which muscle? I have told this mnemonic also before. नाम बड़े दर्शन छोटे, that is gluteus maximus. Maximus नाम बड़ा है but दर्शन छोटे है, मतलब it is supplied by the inferior nerve. Okay, so the inferior gluteal nerve supplies the gluteus maximus. Very frequently asked question. It is asked 100 times in the exam. So the rest of the two, that is gluteus medius and minimus, they are supplied by the superior gluteal nerve. Now we also know that the function of gluteus medius and minimus, what is the major action? They cause abduction. While the gluteus maximus, the major function is extension. The major function is extension. Along with abduction, the gluteus medius and minimus, they stabilize the pelvis. Now when you have superior gluteal nerve injury, basically your abductor muscles are gone. And how do you remember the Trendelenburg sign? In the easiest way is, imagine like a weighing scale, जो तराजू होता है, right? जो typical वाला होता है. So when you put weight on one side, okay, so you have the two sides of that weighing scale. When you put weight on one side, so automatically the other side comes up, right? The other side comes up. Now consider it like that. So if this is the side where you are testing the superior gluteal nerve, you are putting weight on that limb, you are putting weight on that limb, so the other side comes up. Okay, the other side comes up. So this is the action of the abductor muscles on that side. So abductor, the gluteus medius and minimus. So if your gluteus medius, minimus, superior gluteal nerve are normal, the other side comes up. That is, the pelvis is horizontal. If your this side is abnormal, on which you are putting the weight, then the other side drops down. The other side drops down, and that is the Trendelenburg sign. So this is what you can see here. This is like your weighing scale which is there, right? So when you put the weight on the side which you are testing, then the opposite side should come up. That means it will maintain the horizontal level because of the abductor muscles. Now if it is abnormal, these abductor muscles are weak, the nerve supply is gone. So the other side will not come up. That means it will drop down. That means it will drop down. Alright. So now you can see that here, if this is the right leg, this is the left leg. So basically, which nerve is injured in this diagram, in this patient in which we are testing this? Right? So remember that where the weight is, that side we are testing, right? So it is your right superior gluteal nerve. That means the right gluteus medius and minimus that we are testing, and the opposite side drops down. Okay, the opposite side drops down. So now if I ask you that this one, okay, read this option C. The right side of the pelvis droops or sags when he attempts to stand with his weight supported just by the left lower limb. What do you think? When will you see this? In which nerve, which side injury will you see this clinical scenario? So whatever side you are supporting, that means that side you are testing. So the left side you are supporting, so that means it is the left superior gluteal nerve. Alright, it's the left superior gluteal nerve which is gone. But in our question, it is the right side which is gone. So we will ask the patient, if you want to test the right side, you will have to support the weight by the right lower limb, and you will see that the left side of the pelvis droops. Is it clear with everyone? So that is why the answer is B. If it was left, then the answer would have been C. Okay. Now, when will you see difficulty in standing from a sitting position? In which nerve injury or which muscle paralysis will you see difficulty in standing from a sitting position? So basically it is the function of gluteus maximus. That means the inferior gluteal nerve. Opposite, when the patient wants to sit from the standing position. Okay, so sitting from standing position is a function of hamstring muscles. It is the function of hamstring muscles. Flexion of the right hip. What is responsible for flexion of the right hip? Your L1, L2 nerve roots, that is the femoral nerve. Okay, femoral nerve is responsible for flexion of the right hip. All right. So that is about it. Please remember, this is very, very important. Trendelenburg sign and the gluteal muscles. All right. Coming to the next question. In a 35-day menstrual cycle, ovulation occurs on which day? Day 12, day 14, day 17, day 21 or day 28? What do you think is the answer to this? Absolutely right. The correct answer is option D, that is 21. Okay. Now remember that whatever be the duration of the menstrual cycle, whenever there is ovulation, then you have the next cycle starting 14 days after ovulation. 14 days after ovulation, the next cycle starts. That means the menstruation starts. Okay. So that means your post-ovulatory phase is the one which is constant. It would be constant, 14 days. Now you have that, it is a 35-day menstrual cycle. The entire is 35 day. Alright. So if this is 14 day, so 35 minus 14, this would be 21 day. So basically your ovulation is occurring on the 21st day. So what you have to do basically is the duration of the menstrual cycle minus 14 days would be your day of ovulation, would be the day of ovulation. So if I ask you, what should be the duration of the menstrual cycle if the ovulation occurs at the mid duration or the midpoint of the menstrual cycle? What is the duration of the menstrual cycle if the ovulation is occurring right at the midpoint? What will be the answer to that? Absolutely right, Mahira, Priya, very correct. So it is 28 days, because if it is 28 days, so the ovulation is at 14 days, exactly at the midpoint, right? That is the other way of asking the question. Now, if the menstrual cycle duration, let us say, is 40 days, then what time there would be the day of ovulation? So you have to do 40 minus 14, that is 26 day. All right, so please remember this, that your post ovulatory phase is the one which is constant and it is 14 days. So subtract the 14 days and you will get the day of ovulation. All right, coming to the next one. Now this is a question which is based on your second messengers. Second messengers, very important topic for your exam. Okay, I have covered this with mnemonics in one of my sessions on Unacademy as well. So of course it was a 1 hour session that we had. I'm not going into the details of everything. Quickly let us discuss this question, that which of the following substance acts on its target cells via basically IP3 calcium mechanism. IP3 calcium mechanism. So before going into the question, let me see how many of you get this right. Is it somatomedins acting on chondrocytes, oxytocin acting on myoepithelial cells, ADH acting on the renal collecting duct? Is it ACTH acting on adrenal cortex, or is it thyroid acting on this? Okay. Ankita says C. I'm waiting for the right answers, guys. Remember that whenever you're preparing for an exam, it is the frequently asked topics that you have to master, and it is one of those topics, the second messengers. You cannot afford to make a mistake in this question. All right, yes. Okay, the correct answer is oxytocin. Now let me quickly tell you this table which I had discussed. So the second messengers, you have cyclic AMP, IP3 calcium, the steroid hormone mechanism, basically the intracellular receptors, the tyrosine kinase, and the cyclic GMP. Cyclic GMP, very frequently asked, again we know it is nitric oxide, the NN wala cyclic GMP, and the atrial natriuretic peptide. For tyrosine kinase, the mnemonic to remember is dirty pig. Dirty tyrosine kinase. Pig is your hormone, that is prolactin, insulin, and insulin like growth factors, and you have growth hormone. Okay, so prolactin, insulin, growth hormone, and the growth factors also come here. So remember the mnemonic is dirty pig, that is tyrosine kinase is pig. All right, steroid hormone, intracellular, we know all the steroid hormones, glucocorticoids, estrogen, progesterone, all of these. Along with that, remember very important, thyroid hormone and the vitamin D also. Now the most important, the confusing list which comes is here, the cyclic AMP and the IP3. Now I've shared the mnemonic for cyclic AMP, that is, the mnemonic is base, flat, camp, and beta HCG. Now what do we mean by this mnemonic is base, flat. Okay, so imagine someone going for climbing a Mount Everest. So first there is a base camp, and that base camp is a flat one to get accustomed to climbing to such great heights. So base camp is flat, so base, flat, camp, and beta HCG. So these are the hormones which are secreted by the basophils in the anterior pituitary. And again another question which is asked, so which hormones are secreted by basophils? Flat, that is FSH, LH, ACTH, and TSH. Alright, so what comes from the acidophils then? Which hormones are secreted by acidophils then? The ones which you saw here in the anterior pituitary, which are tyrosine kinase, that is prolactin and growth hormone. The remaining one, prolactin and growth hormone, which act by tyrosine kinase. CAMP stands for, so flat we have already covered here, that is FSH, LH, ACTH, and TSH. Now next you have is CAMP. So the CAMP is calcitonin, ADH calcitonin, MSH, and parathyroid hormone, again frequently asked. Next is beta HCG. So beta for beta receptors, HCG is HCG. HCG ka C is CRH, and you have glucagon. So you can see we have covered the entire list here with this mnemonic. So beta HCG itself is beta HCG, plus it stands for the mnemonic beta receptors, HCG, the CRH and the glucagon. Is it clear with everyone? How do we remember? Most important to remember here, it is ADH ka V2 receptor. ADH ka V1 receptor is here. ADH ka V1 receptor is here. Now to remember the IP3, for IP3 remember P3, basically P3 helps you to remember that you have the posterior pituitary hormone, that is ADH and oxytocin. ADH may it is V1. So to remember IP3, I helps you to remember that it is the V1 receptor, and P3 helps you to remember the posterior pituitary hormones, oxytocin and ADH. I is V1, and the rest of your hypothalamic, the hypothalamus wala, posterior pituitary and hypothalamus go together. So the releasing hormones are also your IP3. Is that clear? What is for CAMP? For CAMP it is calcitonin. Look here, it is calcitonin, ADH, MSH and PTH. Alright. So remember, this is the mnemonic which helps you to remember all the second messengers. In that, the most important to remember, I told you that the V1 for ADH, V1 is I when we write Roman 1. So it is IP3. And V2 will come in the dusra wala, that is your cyclic AMP. This is most important. Out of this V1 and V2, okay, ADH ka V1 wala action and V2 wala action, kidneys pe kaun sa hota hai? So these are the newer names for your ADH receptors, V1, V3 and V2. Previously they were V1AB, V1AB and V2. Okay, so you can see that V2 is the one which acts on the kidneys, that is collecting ducts. Again, to remember that we have two kidneys, so that is why in kidneys it is V2. Remember that in kidneys it is V2. Rest you can remember as the older name, it is V1. Okay, and you can see that V1 and V3, that is which were previously called V1, they act via IP3 and the V2 acts via cyclic AMP. Alright, so now let me go back to the question. Now you will remember. Now you will remember this. Now somatomedins acting on chondrocytes. Tell me what will be the second messenger. Somatomedins acting on chondrocytes. Somatomedin is nothing but IGF, insulin-like growth factor. What would be the second messenger here? What would be the second messenger here? Will it be cyclic AMP, tyrosine kinase, IP3, cyclic GMP? What would it be? So insulin-like growth factor, dirty pig. So it would be tyrosine kinase. Very good. Oxytocin. Oxytocin acting on myoepithelial cells of the breast. We know oxytocin is posterior pituitary. So it will act via IP3. ADH acting on renal collecting duct. Renal 2 kidneys. So V2. And V2 we know is cyclic AMP. ACTH. ACTH comes in our base flat camp. Okay. So it acts via cyclic AMP. Cyclic AMP. Thyroid hormone. Thyroid hormone will be your nuclear receptors, the intracellular receptors. So what is the answer here? IP3 is your oxytocin. IP3 is your oxytocin. Alright. So I think this you should remember forever. It is absolutely important to know the second messengers. Coming to the next question. Which of the following would cause an increase in the glomerular filtration rate? Again, a favorite with the examiners for all the exams, be it NEETPG, AIIMS, whichever exam. Alright. So what do you think is the answer to this? Which of the following would cause an increase in glomerular filtration rate? Very correct. It is the constriction of the efferent arteriole. It is the constriction of the efferent arteriole. Again, let me tell you the concept. Now, how is glomerular filtrate formed? You have the efferent arteriole, you have the glomerular capillaries here, you have the glomerular capillaries here, then you have the efferent arteriole. So what gets filtered from the glomerular capillaries? That is what forms your glomerular filtrate. Alright. So you can see the pathway is afferent, glomerulus and the efferent. Okay. So to understand this, the best mechanism is like understanding a network of roads. That is like, let us say highways, and you have bypass. Okay. So now when you do constriction of the efferent arteriole, suppose we constrict the efferent arteriole. If you constrict the efferent arteriole, so basically what we are imagining is, like suppose this is the road to go, you know, all the people are traveling through this road, a pathway. This is the pathway that everybody is following, and here you have a constriction. That means you are making that road narrow. So that is why, because when you make this road narrow, what will happen is you will see the traffic accumulating. You will see the traffic accumulating behind that point. So you will see that all the traffic will get accumulated here in the glomerulus. And now, because there is, you know, traffic jam, so what we do when there's traffic jam, we look for an alternate pathway, alternate route. So the alternate route here is your glomerular filtration. So that is why when you constrict the efferent arteriole, the glomerular filtration rate increases. Of course, there is a certain point. If there is too much constriction, then it decreases as well. Okay. So remember it like that. Efferent is like your, you know, the final path which is there. If you make it narrow, there is traffic jam behind in the glomerulus. That means basically increased hydrostatic pressure, and that is why they find the alternate pathway, that is the glomerular filtration. Opposite will happen. Okay, opposite will happen if you constrict the afferent arteriole. Now when you are constricting the afferent arteriole, basically that means the traffic, the number of vehicles which are going through that path is itself less. The afferent itself is less. When the afferent itself is less, that means there would be no traffic jam. If there's no traffic jam, that means it will follow its normal pathway. It will go through the efferent arteriole, and that is why the glomerular filtration rate, that means the alternate pathway, जो bypass है, उसमें traffic कम हो जाएगा. Okay? Is that clear? So what is NC here? NC is nothing but no change. No change. If I go into this topic in detail, it will take me another half an hour. I'll discuss in one of my upcoming sessions. Okay. So is this concept clear? To remember the afferent arteriole, the glomerulus, and the efferent arteriole. And here you have the bypass route, which is the glomerular filtration. So if you cause constriction here, the bypass ka traffic will increase, so the glomerular filtration will increase. If you cause constriction here in the afferent, so the incoming traffic is itself less, so all of it can go through the afferent. Okay, so the glomerular filtration rate will decrease. So constriction of afferent decreases the GFR, constriction of efferent increases the GFR. Okay, is it clear? So as I said, I'm not going into details. Rest of it I'll cover it in one of my upcoming sessions. Okay, next question. Which diagnosis is correct? Now what is the question? A 28-year-old man receiving lithium for bipolar disorder becomes polyuric. Urine osmolality is 90. It remains at that level even when he is given a nasal spray of DDAVP, that is desmopressin. Now desmopressin is nothing but your vasopressin, that is ADH. So anti-diuretic hormone. So in spite of giving this desmopressin, that is the anti-diuresis, it is not happening. Okay. The urine osmolarity is not changing in spite of giving desmopressin, that is ADH analog. So what is the answer to this? Now remember a general rule. Whenever you have any condition which is central and which is peripheral, for example, let us take diabetes insipidus. So you have central diabetes insipidus and you have peripheral, that means the target organ, which is the kidney, that is nephrogenic diabetes insipidus. Now whenever you have central means the production of that substance is less. So that means the ADH itself is less. Peripheral means there is target resistance, there is target organ resistance. Okay, so in that opposite will happen, like you have an insulin resistance. So to overcome the resistance, we increase the force, right? So the ADH will rather increase, but in spite of increasing, the target is not responding. If you give ADH in central diabetes insipidus, it will treat the condition. If you give ADH here, it will have no action because your target organ itself is resisted. Okay, the target organ itself is resistance. Okay. So now what you are seeing here is, in spite of giving desmopressin, the osmolarity is not changing. So that means central diabetes insipidus is out. Central diabetes insipidus is out. Answer is nephrogenic diabetes insipidus. Okay. Here the urine osmolarity is less. There is polyuria. There is polyuria. Okay. So the answer is nephrogenic diabetes insipidus. The mechanism of action is we know that ADH acts on the kidney by which receptors? We just saw that kidneys are 2, so it acts by V2 receptors. So what is the mechanism of action of lithium is, so if this is the site where ADH binds, lithium does not allow the ADH to bind here. It does not allow the ADH to bind here, and that is why it is like resistance, the target organ resistance, and that is why it leads to nephrogenic diabetes insipidus. Alright, please remember this. So the answer is nephrogenic diabetes insipidus. Central mein, when you give desmopressin, the symptoms get resolved. Now this is a very interesting question. This is basically based on, as you see in the options, this is a question based on your penile lesions, the precursors for malignancies, the pre-malignant lesions for malignancy, the penile malignancy. Okay, I hope all of you understand the terms here. What is condyloma acuminata, what is erythroplasia of Querart, squamous cell carcinoma, Bowen disease and verrucous carcinoma. Before we jump to the question, I want all of you to understand the basics, the important one-liners that are asked, the catch point in the questions that are given to diagnose these conditions. For condyloma acuminata, what will you remember? What is the first thing that you should look for condyloma acuminata in the question? These are basically genital warts. Warts are associated with human papilloma virus. Can you tell me in the histopath what is the change that you should look for with human papilloma virus associated conditions? What is the histological change which is very important to check for? The vacuolization which happens in the epithelium, that is called as chyliocytosis. That is called as chyliocytosis. So these are the most important points that you should remember. Alright. Now what is a giant condyloma acuminata? A giant condyloma acuminata, nothing is but a malignant lesion which is verrucous carcinoma, which is also called as, very good, chyliocytosis, very good, which is also called as the giant condyloma acuminata. So it is the verrucous carcinoma. Okay. Now what is erythroplasia of Querart and Bowen disease? Now both these terms they come under Bowen disease. Now Bowen disease, erythroplasia of Querart, these are your precursors for squamous cell carcinoma, while condyloma acuminata is a precursor for verrucous carcinoma. So in penis you might have verrucous carcinoma or squamous cell carcinoma. Bowen disease is your precursor for squamous cell carcinoma. Now if this Bowen disease, it affects the glans penis, then the term used is erythroplasia of Querart. So the most important thing to notice here is that erythroplasia is when it affects the glans penis, while Bowen disease, it is when it affects the shaft of the penis and the scrotum. Alright. So erythroplasia, as the term says, it would be red plaque. It would be red plaque at the glans penis. Bowen disease might be red or it might be a scaly, it might be white colored plaque also. Alright. Similar to this, there is other term that you should remember, which is Bowenoid papulosis. Bowenoid papulosis. Now what is the difference between Bowen disease and Bowenoid papulosis? Anyone? Clinically, what should be the catch points to diagnose this? Now Bowenoid papulosis is again associated with HPV and it is seen in younger patients as compared to Bowen disease. Bowen disease has a high chance of converting into malignancy. In Bowenoid, the rates of malignancy is less than 1%. Okay, so basically it is more of a sexually transmitted. Skin to skin contact can also give Bowenoid papulosis. Now since it is papulosis, that means you will see multiple papules. You will see multiple papules which would be brown colored. Okay, which would be brown colored. Now Let me show you the image. So now tell me, what do you think is this? You are seeing a red lesion at the glans penis, so this becomes erythroplasia of Querart. What do you think? What is this? How does this lesion look like? So these are the warty lesions. These are the genital warts. So this is condyloma acuminata. Which is HPV associated. And where you see the coilocytosis, you can see the vacuole around the nucleus. There's a clear space. There's a vacuole. So this is coilocytosis, vacuolization. And what do you think is this condition where you are seeing multiple papules, multiple brown colored papules? This would be Bovinoid papulosis. Alright. So now again let me show you this. These are your precancerous lesions in the penis. Bovinoid papulosis, you will see multiple papules. Erythroplasia of Querart, which is basically Bowen's disease affecting the glands. And remember, there's one more condition which is lichen sclerosis. It is a condition which has no association with HPV. Rest of them you can see are HPV associated. Bovinoid papulosis, erythroplasia, they are HPV associated. So if you get the question, which of the following precancerous lesion of penis is not associated with HPV, then it is lichen sclerosis. Now you can see progression to cancer less than 1%, 5 to 30%, 5%. So Bovinoid papulosis has the least chances of turning into penile cancer. The chances are high with your Bowen's disease. Bowen's disease has high chances. Is it clear with everyone? So whatever points I have told you about the penile lesions, okay? So now let us see the question which is asked here, and now let us solve the question. So a 48-year-old man, velvety red plaque on the glans penis. As soon as I see that, the first thing that comes to my mind is erythroplasia of Querart, right? So this is a precancerous lesion, so there are dysplastic changes involving the entire epithelial thickness, but there is no invasion. There is no invasion. So the answer is erythroplasia of Querart. Okay. I'll be sharing the PDF as I told. I'll share this PDF with the images after the session on the Telegram group. I've already shared the PDF without the images which I had made in the morning. I've made some changes after that. All right. I'll share it on my Telegram group. Okay. Now let's move ahead. So that we covered our penile lesions. Everything I've included in that one question. Next question, again a lengthy question. Last line to be read first. Which of the following is most likely to be decreased or absent on red blood cells from this woman? Now which woman? I have to see which is this woman. So this is a woman, 49-year-old, anemia. Every morning her urine is dark red color. As soon as I see this, I do not even need to read the rest of the question. It saves a lot of my time. And because when I see dark red urine in the morning, okay, the number one thing based on the options I can see, what comes to my mind is, what is the diagnosis here? It is also given that AIIMS test and sucrose lysis test is positive. Very good. The answer is PNH, paroxysmal nocturnal hemoglobinuria. The term itself says it is nocturnal. And so there is hemoglobinuria. That is why it is in the morning there is dark red color urine. Can someone tell me why is it nocturnal? Why is it nocturnal? Why is it nocturnal? So before that, let me tell you the pathogenesis for PNH. So in PNH, basically there is increased complement activation. Why there is increased complement activation? Because there are decreased inhibitors of complement. Now which are the inhibitors of complement? You have CD55, which is decay accelerating factor, and you have CD59, which is membrane inhibitor of reactive lysis. Now these are present on your blood cells, not only RBCs, on neutrophils and platelets also. Now how do they inhibit the complement? CD55, it's a decay accelerating factor. So it inhibits your C3 convertase. While your CD59, which is membrane inhibitor reactive lysis, It blocks the membrane attack complex. Okay, now in this pathway, the complement pathway, this is where your CD55 is acting. So it inhibits the C3 convertase. So C3b is not formed, while your CD59 comes later on. So you can see the membrane attack complex. It prevents the membrane attack complex from acting. Okay, so remember that CD55 and CD59. 59 comes after 55, so it inhibits the membrane attack complex, the final step. CD55 comes before, so it inhibits the initial step, that is the C3 convertase. Now both these proteins, they are present on the cell membrane, we said, and they are linked to the cell membrane by this GPI proteins, So if your GPI is deficient, that means automatically CD55 and CD59 would be deficient. For this GPI, we need a gene which is called as PIGA gene. So GPI के लिए हमको लगता है PIGA gene, which is located on X chromosome. So if the gene is asked for PNH, it is PIGA. So basically there is a deficient GPI, the anchor proteins for CD55 and CD59. So the basic thing is there is increased complement activation in PNH which is happening. That is why there is RBC lysis, so there is hemoglobinuria. Okay, so this complement activation occurs more in the acidotic states, and we know that sleep is one of the acidotic states, and that is why there is nocturnal hemoglobinuria. Exercise, acidotic state, increased complement activation. So that is why the test which we do for PNH, the HAM test, basically it uses acid to look for RBC lysis. The other test for PNH is your sucrose lysis test. So remember that the HAM test is based on the acidotic activation of complement, and you have the sucrose lysis test. So what will be the answer now? It will be CD59. It would be CD59. Okay. So remember CD59, which is MIRL, and you have CD55, which is decay accelerating factor. These are the major ones which are responsible, the CD markers for your PNH. Now, can you tell me a drug which is used in PNH? The monoclonal antibody which is used in PNH, it targets the C5 complement. The monoclonal antibody used in treatment of paroxysmal nocturnal hemoglobinuria, basically it decreases the complement activation by acting on C5. Which is it? Very good. It is eculizumab. If you have seen the image very carefully, it is given here eculizumab. Again, a very potential question and commonly asked. So eculizumab, it acts at C5. It is a monoclonal antibody, and that is how it decreases the complement activation, and that is how it's used in the treatment of PNH. So remember this very, very important point as well. All right. Is it clear about your PNH now? So remember HAMS test, sucrose lysis test, morning में dark color urine, CD59 and CD55, and eculizumab is used in the treatment. Can anyone tell me, have you read about this AIRE1? In which condition is this gene defective, AIRE1? Anyone? AIRE1? So AIRE1, it basically stands for autoimmune regulator. Autoimmune regulator 1. Very good. So autoimmune regulator 1. Can you tell me the condition? It is autoimmune polyendocrinopathy syndrome. Polyendocrine. So multiple glands are affected. Type 1. Okay, autoimmune polyendocrinopathy syndrome 1. Yes, so it affects the thyroid also, the pancreas also. So remember, it is your AIRE1 gene. Yes, autoimmune polyendocrinopathy syndrome 1. Okay. Coming to the next question, again a lengthy question. Read the last line. Which of the following is the most likely diagnosis? Second last line, the lesion measures 1.2 centimeter. Let me look at the other clue. When I read a 17-year-old man, nocturnal pain in the bone. He relates the pain is quickly relieved by aspirin. Catch points here, I do not need to know anything else to diagnose. So there is nocturnal pain. It's a 17-year-old boy, so young boy. Bone pain at night, relieved by aspirin. Round radiolucent area with central mineralization, and there is thickened bone. The size is 1.2 centimeter. What is the answer? Absolutely right, osteoid osteoma. Please, in a hurry, do not mark osteoma as the answer. Okay? Do not mark osteoma as the answer. It is osteoid osteoma. Now, quickly, let me tell you about osteoid osteoma. So, osteoid osteoma, it's a cortical based tumor. It's a cortex based tumor. The radiological hallmark, there would be a central nidus. If you see the term nidus, it is osteoid osteoma. The clinical feature hallmark is, it is night pain which is relieved by aspirin. What is the treatment? The treatment of choice now is radiofrequency ablation. Radiofrequency ablation. What do we do in that? The nidus which is responsible for the pain, it is the active tumor area, we ablate that area. So how do you identify the osteoid osteoma? You would see this nidus which is there, and surrounding that there is a sclerotic bone. You see the bone thickening. So you will see a nidus, and surrounding that you will see the reactive sclerotic bone. So the nidus is what is your active tumor area which causes the pain. Now it is believed that the pain in osteoid osteoma is basically due to release of prostaglandins. It is due to prostaglandins, and that is why aspirin relieves the pain in osteoid osteoma, because prostaglandins are given as the cause of pain in osteoid osteoma. So when you give aspirin, prostaglandin inhibited, so the pain is relieved. So these are the catch points for osteoid osteoma. Very, very, very important. Absolutely important to know this. Now, can you tell me what is a giant osteoid osteoma? Which tumor is also known as giant osteoid osteoma? Giant osteoid osteoma is nothing but a osteoblastoma. It is osteoblastoma. The most common site for osteoblastoma in the question they'll give you is the vertebra. It is the vertebra. While osteoid osteoma is more in the long bones. Like you see here, femur neck is a very common site. Femur neck is a very common site for osteoid osteoma. While osteoblastoma, it is seen in the vertebra. Osteoid osteoma, we call it generally when it is less than 2 centimeters in size. More than 2 centimeters, we call it osteoblastoma. Alright? It is osteoblastoma. Not giant cell tumor, it is osteoblastoma. Alright? So I hope this is clear now. All the points about osteoid osteoma. The last question for the day. The arterial circle of Willis contributes greatly to, as I said, lengthy question, last line pad lo, samajh jayega. Which of the following vessels does not contribute to the circle? Which circle? The circle of Willis. Okay. So, circle of Willis, I hope all of you know the circle of Willis. The arteries which contribute to circle of Willis, you can see that this is what is forming the circle. This is where you have the circle. Okay. The circle which you see is this circle, right? It is the circle which is you see here. So the arteries which are contributing to the circle of Willis, as you can see here, is your PCA, right? This is the PCA, which is the terminal branch of basilar artery. Then you have this artery, which is the posterior communicating artery. So one is PCA, second is PCOM. Then you see this artery, which is the internal carotid artery. Then you see this vessel, which is a branch of internal carotid, which is the anterior cerebral artery. And then you see this, which connects the two anterior cerebral, that is the anterior communicating. So in the circle of Willis, basically you have the PCA, you have the posterior communicating, which connects the internal carotid artery with the posterior cerebral artery, and you have the branch of internal carotid artery, which is the anterior cerebral artery, and you have the anterior communicating artery. Okay, so what we see here, that this artery, which is a branch of internal carotid, which is the middle cerebral artery, it does not contribute to the circle of Willis. This has been asked very frequently, alright? It has been asked very frequently. So remember that middle cerebral artery, it goes laterally, and that is how it does not contribute to the circle of Willis. So if this is the circle of Willis, your middle cerebral artery is outside that. So it does not contribute to the circle of Willis. Very important point. Other point that I always emphasize here is this posterior communicating artery which connects the ICA with the PCA. It is a branch of which vessel? So is it coming from ICA to PCA or PCA to ICA? It is a branch of what? PCOM is a branch of which artery? PCOM is a branch of internal carotid or PCA? It has to be branch of two only because it is communicating the two arteries. PCOM is a branch of internal carotid artery. Please remember this. It comes from ICA and it goes to PCA. It comes from ICA and goes to PCA. So these are the two very, very important points to remember in your circle of Willis. That what are these 2 points? The 2 points are that MCA does not contribute to circle of Willis and PCOM is a branch of internal carotid artery. PCOM is a branch of internal carotid artery. Remember these 2 points about circle of Willis. Alright. So the answer here is your middle cerebral artery. The answer here is middle cerebral artery. Is it clear? Alright. So that's all for the today's session. I think we had a very intensive session. We discussed so many important points. Each one of these is an important topic in itself, be it your second messengers, the penile lesions, the circle of Willis, osteoid osteoma, the pharmacology calculation that we saw, the Trendelenburg sign that we saw, the radial nerve injury that we saw, the PNH which we saw. All of these are absolutely important. Make sure you make notes of this session so that you revise before the exam and keep revising it. It is absolutely important. Guys, this was just a trailer of the many sessions that I take, and I'm planning to come up with many free sessions on Unacademy as well. I hope you're following the sessions on Unacademy. I've also shared a link of the form, the Google form, to share what topics you want me to cover in the upcoming free sessions, because my agenda is to help you in the topics which you find difficult. Okay, I can simplify those topics for you. So please fill up that form. Let me know the topics, the time which is convenient. All of these you can let me know in the Google form. It is there on my Telegram group. You can drop me a message. I can share the link. I'll also share the link of the Google form here in the comments after this session. So please fill up that Google form. I update about my sessions on the Telegram group, Dr. Nikita's Rad Synapse. As I said, I'll update this PDF with the images also on my Telegram group after this session. Alright. So yes, that's all for today. I hope you have enjoyed the session. You've learned a lot out of it. And goodbye. Take care. Keep studying, keep revising, and keep winning. Signing off for today, Dr. Nikita here. I'll see you with many more discussions on my Telegram group. Goodbye. Take care.